So Meenakshi,
Yeah.
they had given us half an hour. So I'll finish almost half an hour and then you take for half an hour. And we don't have, if it purely depends on time. If there is no time, we don't give question and answer session then. That's what we have been doing before also. And you can leave. But if there are 5-10 minutes, we can address questions.
Okay. Yes.
Morning, sir.
Morning, Ashish. How are you?
Yes, how are you, sir?
Yeah, I'm good.
So when
Hi,
are we
hi,
going
Ashish.
to see your beard look, sir? Hello, sir. Good morning, sir. Subhash.
Good morning. तो बोलिए कब शुरू करना?
Beard look, when will we see, sir?
Okay. It is only a matter of a month's time.
So I think we have around 69 participants.
That's more than enough. Can we start?
Yes.
Okay, then you can open. I'll open my presentation.
Sir, any videos in your presentation?
Sorry, no videos.
Okay.
Okay, so you can see the screen, no? Full screen.
Yes, you can.
Yes, sir.
And you can hear me, obviously. So good morning, friends. I'll be speaking for next half an hour or so on transient neurological deficits. And arbitrarily, it has been kept as 24 hours because, you know, transient ischemic attack, the traditional definition is 24 hours, even though we know that they last hardly for a few minutes. But even now, the definition is 24 hours. And if you take a definition of the relapse of a multiple sclerosis, that's also taken up to 24 hours. So anything which is less than 24 hours in neurology is defined as transient, even though we know that it can be only for a few seconds to few minutes. Now, I'm telling you one personal story of mine, which might have happened with you also. Imagine that you call a mechanic because your car is not starting, it's not working. And before he comes, your car again starts running. And when the mechanic comes, he says, well, all is okay. Why did you call me? You are fine. And he does very cursory, superficial checkups and lets you go. And you go on a picnic next day morning. And suddenly on a highway, your car stops. And then you don't know what to do. So he's a bad mechanic. He did not check that what is the fault with this. He could not predict that this car is going to stop again. Believe me, it has happened with me on so many occasions, and I have been very embarrassed. But when it comes to human beings, after a transient deficit, if you are like that silly mechanic, then the cost can be very high. The person can die, or he may be left with a devastating deficit. So we should not be like that mechanic. We should give proper attention to a deficit, even if it is transient, because transient neurological deficit may be the proverbial lull before the storm. Now, transient neurodeficit is always a retrospective diagnosis. You know, you cannot look at a deficit and say, well, it may be transient. You know, many people did not give TPA to stroke patients up to 3 hours, thinking it may be transient, it may go. No, transient deficit is a retrospective diagnosis. By the time you are talking that it's a TIA, there should be nothing. Patient should be absolutely normal. It has its own challenges because there is some chance of subjective recall bias. The patient may not exactly remember what happened. You may have realized that when you ask the patient some questions, he asks his wife, oh, did I speak properly? Then the wife gives the answer. So therefore, you may require a collateral history from others. Yet it's important for you to ask all the questions in most detail because it's important. Appropriate evaluation and investigation is the key to come to a conclusion that what must have been the cause of that transient deficit which the patient experienced. Now, neurology is very colorful because of this transient neurological deficit. There are at least 50 causes which can cause it, but the most important is transient ischemic attack. If you take all transient neurological deficits, I think 90% will be because of the vascular transient ischemic attacks, and the rest of them is a huge spectrum. Can be because of seizure, syncope, migraine, aura, vertigo, menieres, drugs, MS, NMO, neuromuscular junction disorders, amyloid spells, transient global amnesia, BIH, meningioma, subdural hematoma, arteriovenous malformation, peripheral nerve palsy, sleep paralysis, drop attacks, and even functional. Now, all of them can give rise to deficits which are lasting for minutes to hours to even a day, and after that they become absolutely all right. So therefore, we must have a good knowledge about all these and ask the appropriate tests to come to a diagnosis. But most important is transient ischemic attack, because the stakes are very high. Now, transient ischemic attack is usually focal in brain or retina. Focality is very important, very rarely global, but usually focal. Less than 15 minutes, 2 minutes, 3 minutes, that's the usual duration. Even though the formal definition is 24 hours, but most of them last only for a few minutes. And it is sudden and maximum in onset. Unlike a migraine or a seizure where there's a Jacksonian march, where there's a spread, TIA is a aphasia with hemiplegia, right from the beginning, right? If it starts progressing, that's a different, then that's a progressing stroke. But otherwise, the typical TIA is sudden curtain dropping over your eye and then resolving. Sudden dysarthria and then resolving. So usually sudden maximum. There can be exceptions. These all are usual things. Now, generally, transient ischemic attacks are negative symptoms. There's always loss of something, loss of power, loss of sensation, loss of vision. Occasionally, they may be positive, but usually negative symptoms, as opposed to migraine or seizures where there are positive symptoms like scintillating scotomas, right? And TIA, because it's a vascular disease, it comes after you hit 40. But once again, sometimes it can happen in young people also. Suppose a patient has a Moya-Moya disease or a fibromuscular dysplasia or a Takayasu syndrome. They can happen in young, but if you take 100 patients, out of 100 patients, at least 85 patients will be more than 40. And usually there are risk factors, but in 10% of the patients with TIA, there may not be any risk factors at all. So the most important thing in this is that it is usually, but we have to remember what is usual. Exceptions can always be done. Now, we should not make a diagnosis of TIA as long as we have not been able to localize to an artery. The moment we see a deficit, we should be able to say, oh, this is a ACA territory deficit, ACA TIA, which will have a lower limb involvement, maybe balance problem, bladder involvement. Or we'll say, oh, it's a MCA territory in which there'll be a aphasia, or there will be a contralateral weakness of the body, or if it's a right-sided, there'll be spatial confusion. You know, I have seen all these patients, so must have you. I have seen a driver who had a TIA in the right MCA territory and he could not go into his transport yard because he was just confused, and later on he recovered. So all the senior neurologists, I mean, as I'm giving this presentation, all the senior neurologists, I'm sure, must have seen an example of each one of them. Then in the posterior cerebral artery, you will have a variety of visual problems. You will have an alexia, which is inability to read. He can see the letters, but he can't read it, and later on it becomes normal. It was transient. Similarly, I know a patient who could not make sense of the newspaper. He saw the newspaper, but he read the letters, but he could not make the meaning out of it. So, or you can have simply a hemianopia. So therefore, we should be able to say this is a TIA in this territory. Vertebrobasilar system itself, you know, it has very well-known symptoms of vertigo and vision problems and dysphagia, diplopia, crossed pain, hiccups, right? So therefore, artery involvement is very important. That is the difference between a neurologist and a GP. For GP, everything is a TIA, and they make a mess of it. But a neurologist should, I think it is this vascular territory. Now, having suspected a TIA, you have to investigate it. So I think these days, for every TIA, we should not debate whether we should do CT or whether we should do this. We should straightway go for a vascular imaging. I do MRI, MRA, 2D echo in all TIAs. You may do CT scan or CT angio, that's a different thing, but vascular imaging is important. And so that by 2D echo, you will look at the heart and will rule out any hypokinetic segment, will rule out any mitral stenosis, will rule out any clot sitting in the heart, right? And then with the vascular imaging, you will rule out any, you can do Doppler here, you will rule out any carotid artery stenosis here, you will rule out any intracranial stenosis here. But you know, in about 30% of the patients, even if you do MRI, MRA, or CT angio, 2D echo, everything is normal. And these patients are called cryptogenic strokes. So in all these cryptogenic strokes, you may also need a transesophageal echocardiography, which will detect a patent foramen ovale. which is an important cause in the youngsters, particularly these days when it can be closed. And if it's an elderly patient who is more than 60, then in these unexplained TIAs, we may have to do Holter, and we may have to do a prolonged Holter, at least for a month or two. So therefore, investigation is very important so that we find what is the cause. And these are the examples of the large artery stenosis here. And if you find this, you have to address this. You have to do revascularization here. This is an example of the intracranial thing. You know, this is of an atherosclerotic patient where there is a terminal ICA block, stenosis causing a transient deficit. Same thing can happen in a young person. If there is a lot of collaterals here, then the same distribution will be called a moya-moya disease. These are the large artery diseases of the brain. But small arteries can also cause a TIA. As you can see here, these are perforating arteries. And these perforating arteries cause what is called capsular warning syndrome. That means they keep on getting a flurry of TIAs 1 hour after 1 hour after 1 hour. You don't know what to do about them. And many of them finally land into a full-fledged stroke. There are case reports where thrombolysis has stopped these TIAs. So it's a very interesting topic in itself. And you can see many times in these patients, we already get diffusion abnormality, even though the patients recover. So that brings me to an important thing, that in TIAs, many times you are having diffusion abnormalities. And it is a marker of the high chance of recurrence. Technically speaking, they are not really TIAs because already stroke has happened, but clinically they are TIAs. So in all transient reversible deficits, we should also look at these diffusion abnormalities because they are a marker of the high risk of recurrence. The formula which has been validated for recurrence is also ABCD2 formula, where you give points to age more than 60 years, 1 point, BP more than 140, more than 90, diastolic 1 point, unilateral weakness 2 points, speech disturbance without weakness 1 point, more than 60 minutes duration 2, 10 to 50 minutes 1, and diabetes 1. And you add them up. And if you have got a score of 6 to 7, then his 2-day risk is almost 10%. So you keep him in a very close surveillance. His 90-day risk is 17 or 18%. So you stratify the risk and take the appropriate corrective measures in these patients. Now they have also added the diffusion abnormality on the MRI to ABCD2 score. Now, we should also remember that in youngsters, mitochondrial stroke-like episodes or MELAS can also sometimes cause deficits which are lasting less than 24 hours. This is a signature MRI of the MELAS. You can see this. This is not actually ischemic. This is a metabolic swelling of the parieto-occipital area of the brain, and we should not remember it. And it also picks up basal ganglia sometimes because these are the places where there's a high density of mitochondria. Now, after TIA, as a transient deficit, we come to syncope. It's a very important OPD problem. It's a transient loss of consciousness without focal symptoms. But patients give a history of faint feeling, dimming of vision, some muffling of the hair, which reflects global retinal and cochlear hypoperfusion. It's very important to recognize that. The common causes are vasovagal, particularly in the youngsters. But as you become elder, postural hypotension, particularly drug-induced, is common. We should look for it. I know one doctor whom I had only put on antihypertensive and he collapsed in a lift and later on got up, and I had to reduce the antihypertensive. And also arrhythmia. We should never miss arrhythmia in patient of elderly syncopes after ruling out other reasons. I know one very important public person who had a syncopal attack during a function. And later on, when I went to see him, because I was called to see him, and he said, no, doctor, I'm perfectly all right. I'm perfectly, there's no problem. Even though he had a syncope, exactly 1 week later, he had a sudden cardiac death. He died. I'm reasonably sure that this fellow must have had an arrhythmia, and which he did not allow to be investigated. So therefore, syncope is one of the markers of sudden cardiac death. It needs to be investigated and addressed by clinical examination, echo, EKG, tilt table test, and if all is negative, then long-term cardiac monitoring, which is very much available these days. Now, next transient deficit is vertigo. Now, vertigo is a very vague term. I think Meenakshi is there. He has given very wonderful lectures on vertigo. So there is a vertigo specialist. We have learned everything from them. We have to know what does the patient mean actually? Is it vertigo? Is it syncope? Or is it just unsteadiness? Many times patients are unable to differentiate, and actually there may also in reality some bit of overlap between them. You know, a syncope may have sometimes a little bit of rotatory component, and a vertigo actually sometimes may have a little bit of sweating also. So that much allowance we have to make, but we have to the best of our capacity think, is it a vestibular syndrome or is it just a cardiovascular hypoperfusion? And other thing which we should ask is that was it an isolated vertigo or was it associated with diplopia, dysarthria, ataxia? Because if it is isolated, then it is unlikely to be a vascular event, but not absolutely ruled out, but unlikely. Whereas if there's a clear-cut diplopia, dysarthria, ataxia, then most likely it is vascular. You know, benign positional vertigo, for whatever vertigo it may cause, patient is able to walk. So this question you should ask him, were you able to walk at that time or not? If they are not able to walk, or even when they come to you, make them sit up. Even though he says that, no, I have no problem, make them sit and make them walk. If they are not able to walk, this may be a vascular event rather than simple benign positional vertigo. Okay, and I must tell you that, you know, twice in my life, I have missed patients of stroke thinking that they are peripheral vertigo because they were very positional in nature, and by next 24 hours, they develop massive strokes. Because by their very nature, all vertigos are positional. So you have to see the entire context. If you see a positional vertigo with a very heavy background of risk factors like hypertension, diabetes, age, always investigate them for a vascular etiology. I remember Meenakshi is very fond of these hints to rule out a stroke in a vertigo patient. This basically hints is a kind of a mnemonic by which we differentiate peripheral from central vertigo. You have to do head impulse test. If you get a catch-up saccade, then it is probably a vestibular neuronitis or a peripheral cause of vertigo. Similarly, if the nystagmus is purely unidirectional, then it's a peripheral cause. But if it is bidirectional, that means vertical as well as horizontal, then it is central. And then you have to look at the skew deviation of the eyes. You know, here you can see the skew deviation in the two different directions his eyes are going. Vertical skew, it suggests a central deviation. But I think in spite of all that, the bottom line is, if in any patient of vertigo you have got vascular risk factors, investigate him, rule out a vascular cause of his vertigo. Now, next is seizures. You see, seizures are generally tonic-clonic movements, either focal or generalized. Sometimes you can have inhibitory seizures, which rather than having abnormal movements, they come as paralysis, which arises from supplementary negative motor area. But more often, seizures present as post-ictal palsy, where the initial seizure is missed. I have also missed it. After so much of experience, you know, one day one patient was brought to me. He was in unconscious state, and there was paralysis on one side, less movement on one side. And I thought it's a massive brain hemorrhage. I asked the attendants, did he have a history of stroke before? They said, yes, he has had 2 strokes before. So I investigated him and everything was normal. His CT scan was normal. And by evening, the patient woke up and became normal. And it turned out that this was a focal seizure with generalization and then post-ictal Todd's palsy. And what the patients meant that he was having strokes before was that he was having seizures because our patients many times confuse these terms. They use stroke for everything, whether it's a heart attack or a seizure. So these clarifications are very important. And I have, later on in my experience, I have seen many patients who have got recurrent focal weakness, recurrent focal numbness, recurrent hemianopic vision loss, even after a stroke. And it turned out that all of them were actually focal seizures. So therefore, focal seizures can be important cause of focal neurodeficits. And I think we should also ask them history of grimacing or confusion or lip smacking during their abnormal behavior, which can recover after some time, and they may all be seizures. So detailed history, MRI and EEG should be done in such situations. Migraine aura is also a very fascinating thing. Up to 20% of patients who are suspected to have TIA actually have a migraine aura without the headache itself. And Miller-Fisher described it as late life migraine accompaniment. This is also called ecaphalgic migraine. It has been observed that as migraine patients become older, when they cross the age of 50, then they may not get headache, but they continue to have the aura, right? So I know of one professor who told me that he sees some visual things which last only for a few seconds and then it becomes all right. But they're very frequent. And I asked him, did he have migraine? He said, yes, I had long back migraine, but now it is not. So I put him on, anti-migraine preventive medication and he became totally all right. So therefore, we have to remember that in late life migraine, you may have only aura without headache, and these can last for seconds to minutes, but usually resolve within 30 minutes. Auras can be visual, sensory, motor, speech, but most common are visual auras consisting of scintillating scotoma, zigzag patterns, raindrop, and many other things, as you can see here. Sometimes you can ask the patient, draw the aura for me, and they'll be able to draw it. One of the most colorful and fascinating syndromes in neurology is transient global amnesia. Again, all the seniors have seen this syndrome. I remember a few patients who just, they look confused to their family because they know who they are, they know where they are, but suddenly they keep on asking the questions again and again. They have forgotten their immediate past of the last few hours, and they are not able to remember their very recent memory, as well as immediate anterograde memory also is affected. So they, to the others, onlookers, they look a little confused, they look a little different, and their procedural memory is intact. They're able to eat fine, they may smile just as a formality, but they're a little confused because you see, it is our memories which make us who we are, and suddenly a chunk of memory is disappearing from our existence. So we just ask a repetitive question about something which you're supposed to know. And I have seen many people in this, including very educated people, and eventually they recover completely within 24 hours. People don't know why they happen. There are studies and studies. Some people think these may be seizures or these may be TIAs, and even hypoperfusion has been documented in PET studies. But what is good is that usually there is no recurrence, and you can give a good prognosis to these patients of transient global amnesia. Now, amyloid spell is a relatively new term with which we should be all aware. These are just like TIAs. They are stereotyped, recurrent, transient episodes of sensory, motor, or visual deficits, and they spread over seconds to minutes and equally resolve within seconds. And when you do their MRI, you find that there is a superficial cortical sclerosis, and the marker of amyloid spells may be acute sulcal hemorrhage. Now, if you miss this sulcal hemorrhage, or if you have done a CT scan which may not pick the sulcal hemorrhage, then many times these patients are put on aspirin, thinking that these are TIAs, and which can be very disastrous in these patients. So in all sudden deficits, I would always prefer that rather than CT scan, we should do MRI. And if you find this sulcal hemorrhage, which you can see here, this black thing on this GRE image, this is sulcal hemorrhage, and this patient was put on aspirin, and eventually you can see how big hemorrhage he had. So we should be aware of amyloid spell, because these are the patients who have got a cerebral amyloid angiopathy, which causes these sulcal hemorrhages and these transient deficits. And why they are transient, we exactly do not know. Then there are a whole range of causes which can cause motor, visual, or unconscious. We call them spells. They are spells because they are just attacks which go away. Meningiomas can sometimes cause spell of weakness. Probably these are seizures, or there may be some other mechanism. Meningiomas are vascular phenomena. They may cause a steel phenomena. Many years ago, there was a very popular term in neurology to be called transient tumor attacks. Fortunately, nobody uses that term now, but tumors can sometimes cause transient thing. By and large, most of the people feel that these are actually seizures. Similarly, subdural hematoma can rarely cause transient episodes because of the hematoma can sometimes expand, and sometimes it can slightly contract and it can cause transient attacks, rarely. AV malformations, not a big brainer because of the steel phenomena. They can cause transient phenomena. AVMs in the spinal cord as well as AVMs in the brain till they rupture, when they will cause permanent deficit. And I think all of you have seen benign intracranial hypertension coming with episodes of visual blurring, particularly transient visual blurring. So any kind of transient, any kind of raised intracranial hypertension, including from BIH or IIH, can cause these transient visual phenomena. Now, multiple sclerosis is becoming very common, and many patients of multiple sclerosis will phone you that they are having episodic numbness. they're having tonic spasms. And every time we are worried whether it's a new episode, but we should remember that most of them are not new episodes. For an episode to be new, it has to last more than 24 hours. And these are just abnormal electrical discharges from the pre-existing plaques, and we can manage them conservatively. But if they last beyond a certain time, beyond 24 hours, then we have to investigate them. Now, metabolic disorders also can cause transient deficits. Everybody knows about hypoglycemia. And interestingly, this hypoglycemia can get sometimes spontaneously also corrected by the body mechanism, but sometimes, most of the times, people feed them, and they can cause from dizziness to even focal neurological deficits. Hyperglycemia, hypokalemia, everybody knows periodic potassium deficits and periodic paralysis, hyponatremia, and even hypocalcemia. So we should keep metabolic cause always rule out in patients of transient deficits, and drugs always in any patient with any neurological symptom, we should think of iatrogenic causes. Phenytoin can cause unsteadiness, carbamazepine can cause unsteadiness, which can become less also over the course of time as the levels fall down. Phenothiazines, antihistaminics, and zolpidem. In fact, my own father once took zolpidem because he had to go somewhere which he thought was a very boring place. He said, let me take zolpidem. And my mother thought he was dead because it acts very quickly. He took a zolpidem, and in 10 minutes or so, he was unconscious. Then doctor had to be called. And after that, I have seen many patients who take zolpidem in daytime and then they just collapse. So therefore, we should always take a drug-induced history, particularly in transient neurological deficits. Interestingly, pressure palsies can also be transient causes, Saturday night palsy, or sometimes you can press even ulnar nerve. After all, it's a superficial nerve, and all of you know this OK sign or this risk drop. They may last for 1 week or so, but if they are mild, then it may recover soon. But we should remember that sometimes such a kind of a thing may also be caused by a small stroke. It's called a hand knob sign because it's exactly at the motor area. And if it's very mild, it may also recover. So we have to keep this knowledge in our mind. Now, these are channelopathies, and I think Dr. Kailash Bhatia has educated all of us and continues to educate us about these. He has shown you hundreds of channelopathies, but usually present as paroxysmal dyskinesias, episodic ataxias. And you know about neuromuscular disorders, not only myasthenia, but early morning paralysis and all, which lasts for a few hours, 24 hours, and many times they recover. Episodic ataxia only for a few hours, and then they recover. So we have to keep them into consideration. Now, another cause of reversible deficits is drop attacks. In children, it can be atonic seizure, but the clue will be mental retardation and other kinds of seizures. In adults, it can be a third ventricular cyst or a colloid cyst that suddenly drop down and then get up. Patients with the established Meniere's disease can suddenly fall down, which is called autolytic crisis, with severe vertigo and fall down actually because of severe crisis, and then CV junction deficits. And there's also an interesting phenomena of drop attacks in middle-aged ladies where you don't know why they suddenly fall down like a log of wood and then they get up. So all these we have to keep at the radar of our mind. And then most important is functional. Some patients you will see, particularly youngsters, generally from the female gender, but it can be men also, young boys. You will see that the history they will give will be non-physiological distribution of the weakness. There will be some stressor in their family, or they may be having some reason to get a secondary gain, for instance, to avoid an examination or to avoid some kind of a litigation, to avoid a court date. That all history has to be taken. And sometimes they may be just non-epileptic attack disorders where there's a primary gain. So therefore, but functional, I would always keep last of all before I have ruled out everything else. And because we should not miss any important diagnosis. So in summary, friends, transient neurological deficit makes neurology very fascinating because only clinicians like neurologists can make analysis and make the proper diagnosis. And spectrum of transient neurological disorders is huge, as I told you, but TIA is the most important. We should not miss that because missing that can be very dangerous. And fundamental to this is knowledge of neurology. Knowledge of neurology and knowledge of internal medicine is crucial to come to a proper diagnosis. And it is not just knowledge, But the knowledge and the proper application of knowledge at a proper time in the proper context is very important. Otherwise, pure knowledge is of no use. Knowledge of and internal medicine is equally important. Accurate evaluation and investigations are key to management. And TIAs or transient deficits is a window of opportunity. Every time we don't get this window, but this is a window of opportunity both for the patient, because patient, if he reports to a doctor with a transient deficit, then he can be absolutely saved from the future. And it's an opportunity for the doctor to show his skills and to help his patient prevent any catastrophe. And that's what neurologists are for. So thank you very much. I think I have finished in time. It's 10:32. So I will now request Professor Meenakshi Sundaram to give his lecture. And if we have any time, then we'll take questions. Dr. Meenakshi Sundaram, he needs no introduction. Meenakshi, you have to unmute yourself.
Yeah, I unmuted.